No, thank you. Great, we're live.
Okay. Well, good morning, everyone. I'm told it's a beautiful day in Boston, and I'm looking forward to the October meeting. I'm Valerie Sullivan, Chair. Joining me today for our October GIC meeting is Bobby Kaplan, Vice Chairman, Brendan Moss, Designee for A&F, Martha Kwasnick, Designee for Division of Insurance, Adam Chapdelaine, Toby Choate, Christy Clenard, Jane Edmonds, Joseph Gentile, Gerzino Gerard, Eileen McInerney, Melissa Murphy Rodriguez, Anna Seneko, Timothy Sullivan, Liz Shabbat, and Tamara Davis. So we've got almost all of our commissioners here today. First order of business, I'd like to ask for a vote on our minutes from our September 23rd meeting. Do I have a motion?
So moved.
Okay,
Seconded.
So great. So Commissioner Kaplan for the first motion and Christy Clenard for the second. So for a matter of process, we'll have our general counsel do roll call, starting with me, Valerie Sullivan, and I am yay on the minutes.
Commissioner Kaplan.
Yay.
Designee Moss.
I'll abstain. I wasn't there.
No problem. Commissioner, I'm sorry, Designee Kwanowski. I can't get it today. Kwanski, I'm sorry.
No worries.
Sorry, Martha.
Thank you. I'll abstain as well, as I wasn't present for the last meeting.
Commissioner Shabbat.
I will abstain. I was not present the last meeting.
Okay. Commissioner Chapdelaine.
Yes.
Commissioner Choate.
Yes.
Commissioner Clenard.
Yes.
Commissioner Davis.
I'm going to abstain because I was not present at the last meeting.
Commissioner Garan.
Yeah.
Commissioner Edmonds.
Yes.
Commissioner Gentile.
Yes.
Commissioner McInerney.
Yes.
Commissioner Murphy Rodriguez.
Yes.
Commissioner Sinenko.
Yay.
Commissioner Sullivan.
Yes.
The motion passes with 12 affirmative votes and 4 abstentions.
All right. Thanks, Andrew. So I'm going to turn it over to Matt. We have a really exciting agenda today, and I am looking forward to especially hearing about the conjoint survey. So thanks for pulling this together to the staff. I know they worked hard, and I'm going to pass it over.
Thank you, Madam Chair. Thank you, members of the commission. If we can move back to slide 2, I'll take a quick look. Oh, there we go. Take a quick look at today's agenda. We do have 3 items to discuss with you today, in addition to our standard CFO update, and we have no votes, simply information for you. So we are, as our chair noted, excited to provide you with a high-level overview of the results of the member survey that we fielded a few months ago. We have, and then secondly, as we have on a few occasions over the last 18 months or so, we will provide you some really interesting data points that provide some insight into how COVID-19 is impacting our membership. That will be provided by Margaret Anschutz and our extraordinarily talented intern, Sabrina Wirtz. And thirdly, we will have our audit firm, CTI, present findings on our routine biennial audits of 3 of our 6 health plans. I will note that Jim will also be walking through a brief review of the resolution of findings from last year's audit of our other 3 health plans, which the commission had requested. So that is our agenda for today. We can move to slide 4 real quick. So a quick review of the executive director's report. Again, per our protocol of the last year or so, we've included a written executive director's report. I will just highlight a few items, but we want to start with a quick calendar review. Next slide. So we have 2 items of calendar review for you this time around. We have the first one here, which shows the work that we've done with you over the course of 2021 and our remaining items of the year. On our next slide, we'll actually be projecting through calendar year 22, including our health benefits and EAP procurements. And this slide, of course, in addition to our routine items, we've spent considerable time over the course of this calendar year digging into the primary challenges that we face at the GIC around our 3 core priorities of health equity, behavioral health, and affordability. We did that understanding that it's important to lay the foundation for our coming discussions about how we're going to address those challenges. So today's meeting will be a brief interlude of sorts as we switch gears and start engaging with you in earnest in November about our coming strategy for the health benefit procurement. So in November, you will see we have a procurement strategy update. We are working hard on this, which will be really the first high-level overview of the process that we've undertaken to develop our strategy. And while we won't go deep into specific details of it, we intend to provide you with some high-level comments about our general direction. And then, of course, we will start in our December meeting our annual work with you to develop our preliminary rates for the next fiscal year 23. You can go to the next slide. So here we're projecting for 22. Note the asterisk here that these items are subject to change. As you can see, there's a lot going on here, and as expected, we have a very busy year ahead. I just want to highlight a few items here. Again, our plan design work, as normal, will continue through March to prepare for the annual enrollment in April. We also have, we'll have a comprehensive overview of our procurement strategy planned in February in advance of the release of both the health, the medical and the prescription drug RFRs. I'm going to talk about a little bit more about those procurements on the next slide. But I do want to note that this lays out all the key steps that relate to our procurement. And I would also note here that we have several votes related to our employee assistance program procurement. So it's going to be a very busy year on top of all of our normal routine work. So I would normally pause here, but let me get to the next slide where I lay out a little bit more detail specific to the health benefit procurement. And then I'm happy to take questions. So I thought it might be helpful to break out the pharmacy and medical benefit into this specific timeline. As I noted in our November and February commission meetings, we'll be presenting to you the more detail coming in February. We wanted to allow time for feedback from the commission at our March meeting before we release the RFR in early April. And then we'll spend the spring and the summer reviewing bid responses and preparing our recommendation to you, which we'll present in the fall. We are also contemplating some public information sessions that are dedicated to the procurement. As you know, we normally have those around the plan design and rate development in January. But we're contemplating in the fall, after we do a presentation of the medical benefit, also giving an opportunity for our membership and the public to provide us some feedback. So I'm going to pause there. If there are comments, questions, concerns, suggestions, we're eager to hear them. There's a lot going on this year and next, as you can see.
Well, Matt, I like that the team and under your leadership has laid out, a look at like the next 18 months. So I think it's terrific. I don't see any questions, so we can keep moving.
Great. Thank you for that. That's for the director's report. Bear with me for a moment. I think in the interest of time, I'm happy to take any questions on the written report. I do just want to take a moment to welcome Leslie Montero to the Group Insurance Commission team, hired recently as our manager of communications. This has been a hole in the organization for quite a while, and Erica Shabelli has been holding up that end of the shop with some help from her team. I think I mentioned in our last meeting that Leslie was going to be joining us, and we're happy to have her. Comments, questions about anything in the written executive director's report?
Eileen, were you going to make a comment? No.
No, sorry.
No, that's okay. All right. I don't see any questions. I think I really enjoy them, Matt. So I can speak for the commissioners. I'm guessing they are enjoying it too. It's good information. It's nice to have it written down.
Great. All right. With that, I think we can move on to agenda item number 3. We can move to the next set of slides. Perfect. So here I will just tee this off by acknowledging some members of our team who have put in a tremendous amount of work on our member preferences survey over an extended period of time. Janine Dewar, Margaret Anschutz, Jim Rust, who oversees that team, our colleagues at Deloitte, who have been very helpful partners throughout this, but also our members for taking the survey, and for our folks, our colleagues in labor with whom we've had extensive discussions about the survey. It's been a real lift for us, but a joint effort. So I want to thank all those folks. Just a brief reminder here that the initial plan with the survey was to release it last fall. But we made the decision to push back that timeline a bit, to make some adjustments to our approach, and to spend more time engaging with our colleagues in labor to address concerns that we had heard from them. This is not your standard survey that most people are used to, but really requires the member, the survey taker, to consider what's important to them in their health plan and really to make trade-offs. It was not an easy survey to take, so we're grateful for so many of our members taking time to complete it. A reminder that these results are a very important set of data points, but by themselves, they won't determine our ultimate strategy. As we have discussed, our engagement strategy is also a very important source of insights and data, as is our ongoing work with our colleagues at Willis Towers Watson, our consultant for this procurement. The other thing I want to note at the outset is to remember that the survey models only what our members experience with their plans and changes to a discrete number of plan design features. And as I've said several times before, we know that there are limitations with regards to plan design changes as to how successful they can be in moving the needle, particularly around affordability. So I've asked my team here to take their time presenting and pause for questions and feedback. This is a sophisticated survey tool, and communicating about it has sometimes been a challenge. So we want to take our time and let you absorb it as we do that. So with that, I want to hand it over to Janine and Margaret. I think Janine's up first.
Thanks, Matt. Good morning, Commissioners. I'm Janine Dewar, and I was the project manager for the member preference survey. I'm going to introduce the results today. So the survey launched on July 15th and was open for 20 days. The GIC sent information about the survey and the survey link over to over 94,600 active subscribers via email and postcards. Deloitte hosted the survey platform and analyzed over 9,000 completed surveys for a response rate of 10%.
Can I just ask you to hold for a second? Can we move to slide 9?
Oh, sorry.
Thank you.
So we reached a 10% response rate, and this is important because that means that based on the sample size, the results are statistically significant. As a reminder, this was a conjoint survey, which is a market research technique used to understand how consumers value different components or features of a product or service. So as Matt mentioned, to some degree, the survey may have seemed difficult, particularly when respondents were asked to choose between health plan features that they didn't care for. But by requiring members to make tough decisions, we can gain insights into how members make trade-off decisions and prioritize health plan features. So I'll get into more detail on that in the next slide. As previously mentioned, the GIC continues to seek feedback in a number of ways regarding the upcoming procurement, and this survey is only one of several tools the GIC will use to inform development of our health and pharmacy procurement strategy. Next slide, please. The online survey presented a series of health packages with varying features. This is represented in the optimization section, which used conjoint questions to capture preferences and trade-off decisions. In other words, it allowed us to gain insight into which health plan changes are most likely to influence a member's plan choice. Examples are changes to deductible, premium, and hospital access. The additional research questions asked members to rate their agreement with statements to understand other factors that influence health plan decisions, like tiering, willingness to change plans, competence in choosing between health plans, etc. The demographic questions were used to gain insight into the characteristics of the survey respondents. And these questions included self-reported age, race, ethnicity, gender, and union or municipality affiliation. Next slide, please. Is there a previous slide? Okay, so thank you. So on the top right-hand side of the slide, you can see how the benefit optimization questions were presented. 2 health plan packages were shown side by side, and members were asked to choose between 2 health plan packages, and this was repeated 10 times. The configuration of these packages were varied for each respondent. Additional research questions asked members to rate their agreement with each question on a scale from 1 to 5. Examples of additional research questions are shown in the table below. And for each question, we can in the future drill down into various levels within and across demographic groups. So with that, I can hand it over to Margaret to further discuss key results and findings.
Great, thank you, Janine. Could we move to the next slide, please? Thanks. All right, so here we begin to take a look at the results of the conjoint survey, and what jumps out right at the top is the top 3 most influential attributes of a benefits package. You see number 1 and number 2 being the out-of-pocket maximum and the deductible. These are significant because these are sort of the higher spend out-of-pocket attributes of a benefits package, and followed third by hospital access. You see the rest of the where the rest of the attributes of a package fall down the line. But really, I thought the fact that the out-of-pocket max and deductible were at the top was very revealing. Wanted to comment that we know from our out-of-pocket report that less than 1% of our households membership exceed the out-of-pocket max in fiscal year 20. That's not to say that we shouldn't be looking more at out-of-pocket maximum, because I think that there's some room there to optimize our benefit package with respect to how much how much our members are on the hook. And I also want to note that these attributes remain constant across demographic groups. Next slide.
Before you move off that, Margaret, sorry, just wanted to point out one item. So when we say premium contribution here, I just want to make sure that we're clear that this is the members' portion of the premium. We're not talking about premium splits. We did not model premium splits between the Commonwealth and our members. That is not a feature that we can change. But what we're trying to model is ultimately what they're paying out of their pocket for their portion of the premium.
Yeah, that's an important note. So when you think premium split, or when you think of premium, it's the member portion. Thanks, Matt.
That's a good, yeah, Bobby has a question.
Please.
Yes, I just wanted to know, Margaret, the out-of-pocket, does that include the copays? Like, were there questions that were specific to copays, or were they, was that a separate
That's a
item?
good question. Very good question, Commissioner. We see the third from the bottom on that on the table on the left is office visits copay. So copay was considered separately from the out-of-pocket max.
Was that, could I just ask, was that made clear, like, to the respondents, like that people would not sort of assume that copays were included in that out-of-pocket? Do you have a sense of that?
I don't want to speak for what people assumed, but we did.
Okay.
We were very well. But I can say is that we were very careful to have hover overs and definitions, like the definition of a copay, that kind of thing in the survey. So we did everything we could to be clear about what we were talking about.
Okay, great. Thank you.
It's a good question, Bobby, and it is kind of an interesting finding that would be at the top, since so few of our members actually ever experience or reach the out-of-pocket maximum. I'm thinking this is more an expression generally about a high level of out-of-pocket obligation on the part of our members. So it's an interesting finding. I think an out-of-pocket maximum generally is probably the feature of a plan that is least well known or understood, because so few of them experience it.
Yeah, it's that fear of the unknown and the skyrocketing costs of healthcare. If you're very sick, can be scary, quite frankly. So again, I'm not going to be anything like Margaret on the interpretation, but the way I experience this response is that unknown is concerning, and that's at the top of their concern list.
Mm-hmm.
Yeah, I think that's right. And I think I'll just add to that. I'm seeing through the data that perhaps the ability to plan, which, our premiums being a stable fixed amount, the ability to plan over the sort of unknown costs for the future. I think there is a strong preference to being able to plan and have we'll get into this later, but perhaps have a slight increase in premiums and a reduction in out-of-pocket max, just for the ability to sort of budget for the year. But that's all coming later.
Okay, Jane, I see you have your hand up. I don't know if you answered it. Yeah.
Thank you, Chair Sullivan. Margaret, I'm just curious, did I hear you say, am I correct in hearing you say that the survey results hold constant across demographic groups?
That's right.
And I was wondering, as you said that, if I'm correct in understanding that, are there any noteworthy or interesting findings, results that pertain to demographic groups? Is there any something that came up in the results that's different by demographic groups?
Yeah, good question. And we are presenting on that in a couple of slides. So I don't want to steal the story from the future slides, but we're drilling into that.
Yeah, I don't see any other questions, Margaret, so go ahead.
Okay, thank you. All right, so on this next slide, we see willingness to move or member migration. The conjoint survey tested to see who is and who is most likely to, who is and who is not most likely to migrate plans, as well as what factors would inspire a change in a plan. On the left side of this presentation, we see plan attributes associated with willingness to change, such as staying with their current doctor and lower cost to members. Subscribers under 44 were the most likely to be swayed by these factors at open enrollment. So that's, again, that's the left side. And that's younger members are more willing to move. On the right side, we see that members who are not likely to change plans are confident in their ability to assess their health plan options. They are satisfied with their health plan, and they plan to stay with their current plan. These responses were associated with members over 55. So what I take from this slide is that if we're looking to address affordability through steering members into more efficient plans, it's the younger members who are more willing to move. However, from a cost containment point of view, moving younger members is not likely to save us much money because they make up such a small percentage of our total member spend. As an example, as a proxy metric here, I pulled the members under 35 make up only 4.9% of the total spending in the broad or national plans. This is an imperfect metric, but really what I'm trying to say is that if we want to move members into a narrow network or some other, similarly designed plan with the idea of it being a more efficient network, we really have a very small amount of spending to affect by that steerage. Questions on this slide, please?
Yep. So Margaret, I'm just curious if the younger age group, do you know if they're younger with families, or are we talking about individual younger people?
That's a good question. So this was, let's see, this is subscribers only, and I'm going to have to look back into the data to see about the distinction between subscribers in an individual plan versus family. We can look into that.
Thank you.
Go ahead, Eileen.
Sure. So I guess I have a comment more than a question, but I think some of the responses, if you're asked kind of just open-ended or kind of in an isolated way about your health coverage, it's not surprising that older people who probably have more established relationships with their carriers would want to maintain them. I guess though the question is kind of like at what price or what cost, right? So it's the ability or the willingness to move. You're not going to tease that out unless the trade-offs are presented, I guess is all I would say.
That's an important point, and there were trade-offs assessed through the survey. So without, throwing up all the survey questions or walking through the survey itself, these results were arrived at by placing, say, a premium differential and associating it with, the willingness to change. So this is all with respect to varying the financial side of the plans. And to your point, you can always say, well, we could go back and increase the differentials, and at what point would that move the older members? But this was, in a limited survey, the point was not finding at what point our older members will move. It was just about assessing how sensitive they were to financial attributes of a benefit package, along with trying to move people.
I don't see any other questions. You can keep moving.
I think you point out, just before we move on, I think, Eileen, Commissioner McEnany, you point out an interesting observation here, which we had as well. And part of the reality is that a 10% increase in the members' share of premium, which could be evaluated in light of some of the features of the plan that they do like to see, is still a fairly modest amount of money when you compare the overall premium, right? So the impact of making that decision for a 10% higher premium or a 5% higher premium really falls more substantially on the Commonwealth and the general fund, and less so on the member, right? So it's, again, we're, as I said at the outset, we're modeling features of a plan that a member experiences, but there is a bigger picture that we all need to be very aware of.
Thanks, Matt. Next slide, please. All right, similarly to the previous slide, when we're looking at tiering, it's once again the younger members who are more likely to respond to a copay differential. So what we have on this slide is our age bands that we tested, as well as in the second column, the percent agree that the tier level costs influence provider choice. We see from the results that about half of our subscribers under 35 say that tiering affects provider choice. This same age group accounts for only 14% of subscriber professional spending, or the amount that is on the table with tiering and steerage at the professional level. But 14%, it's not nothing, but really if we are looking to build strategy around affordability and cost containment, this is certainly not a silver bullet, far from it. So I'm going to pause for questions about the tiering slide that we're looking at.
I don't see any, Margaret.
Okay. All right, there's a lot going on in this slide, and I think it merits some time in just setting up what we're looking at here. So this is essentially a visualization of our cost-benefit analysis. What you see here on the x-axis or the horizontal axis is how we begin to plot, and the y-axis is how we begin to plot the trade-off between cost or GIC investment on the x-axis and member preference on the y-axis. So again, that horizontal axis is GIC investment in dollars, and that vertical axis is member preference. Deloitte built us a tool that enables us to plot different benefit designs in terms of GIC investment and member preference. The ideal state for any of these benefit packages would be one that both decreases GIC investment and increases member preference. This area would fall into the top left quadrant on this slide. That's our sweet spot. That's where if a package lands there, it both saves money and increases member preference. So again, top left is really where you want to be. The dotted, excuse me, the dotted arch across this graph is called the efficiency frontier, and it represents where the most efficient packages, so the optimized packages for the amount we're spending with respect to member preference. So that efficiency frontier, if a benefit package lands there, then we know we're getting the most bang for our buck. I feel like I should pause here for questions about this graphic. It's important for the next few slides, as well as understanding how we're using the Deloitte benefit tool. Any questions here?
I think maybe hold off the questions until you show us what the data showed, and then maybe come back to this slide as the framework. But for me, this is very helpful.
Okay. Great. Next slide, please. Okay. So now what we're doing is we're looking at the efficiency, or we're looking at that same graphic, but we're drilling in. That curved line is the efficiency frontier. And the dots on that curved line represent benefit packages. On this particular example, You see package 20 circled in red as the only package that fell in the efficiency frontier. Again, that's decreased cost to the GIC, increased member preference. And you see that that's pretty close to both axes there. So it's not a tremendous change either in decrease of investment or member value, but this is a package that would be optimized over our current state. All right, next slide, please. Great, here is an additional drill down on what the Deloitte tool coupled with our member responses will allow us to do. This is an example of how the tool will help us inform future benefit package development. For any change in plan attribute, it's that column on the left, such as out-of-pocket maximum, which we know scored very high in member preference. The Deloitte tool will also represent the cost associated with that. And then it pulls all these attributes together along with all of the associated costs and plots it on that, on that graph, the cost-benefit analysis graph. So that's the way we're going to use this tool in respect to the procurement. You know, we know that subscribers expressed a preference over the status quo for a lower deductible, lower out-of-pocket maximum. And I think the insight in this slide is that the trade-off they were willing to make was an increase in premium for the lower out-of-pocket costs. But I think very importantly, as Matt has underscored, we're modeling here the members' premium contribution, not the full contribution. And if we, you know, there's a roughly 25-75 split with most of the population, though that varies a bit. And so we're talking about really a small part of the premium being increased for that trade-off. So before I hand the presentation back to Matt for the key takeaways, I think I would like to pause now for questions.
I know you said you were going to provide us some differences in demographics to Jane's question.
Yep.
So that was just on the younger person's interest in the tiers?
That's right.
Okay. Nothing else came out, differences in demographics, except
you know,
for
there
interest. Yeah, go ahead.
Yeah, there are, as you would expect, some difference in demographics, but nothing we felt that merited presenting at this time.
Okay. I don't see any other questions. So
can
let's
I
go. Oh yeah, go ahead,
this
Anna.
Is Anna.
Yep.
Can't raise my hand. So this is really great work to the whole team. Thank you so much. And I really personally love this graphic with the frontier. I had a question about just the analysis. One thing that can be done in the survey is when you have a response rate around 10%, you can like look at the characteristics of the responders relative to the characteristics, right, of the whole population, and sort of try to see like, did certain groups respond more than others, and then, you know, weight so it's more representative. Did you guys do that?
Not yet, but yes, that's very much on my mind. So we want to look at how representative this is.
Okay, great. Because then like you have a sense of exactly like, you know, for the people who represent different groups, like how does this if you were to, you know, try to get it representative of the whole population, are the results different at all? I think that'd be really interesting to see.
Absolutely. Yep. Thanks, Anna. Yeah, and we're working on that.
I'll actually, I'll speak to that briefly at the last slide that I have on this part of the presentation. All right, so as I think you can probably appreciate, we didn't see any sort of explosive new findings here. It actually affirmed much of what we've heard and known for some time. We know our membership is very sensitive to changes in out-of-pocket costs. This survey confirms that and notes that they're willing to trade reductions in those out-of-pocket costs for a marginal increase in their portion of the premium. I'd say generally speaking, our members highly value broad access to hospitals, as we've noted, something that we also see in the relatively modest and declining or stable enrollment in those plan designs that exclude certain hospitals from their networks. Members overall are satisfied with the plans that they're currently enrolled in and don't expect to make changes, at least for the coming year. However, it is noteworthy that, as Margaret noted, that underneath the high-level findings, we do see among our younger members a little bit more restlessness for new, more affordable options that could include trade-offs among other plan features for moderate premium. So I think these are the general takeaways that we have high level that we wanted to share with you. As Margaret noted, we are not done with this work. If you can move to the next slide, we can talk a little bit about next steps. And I will first note that there are additional, more detailed slides within the deck, in the appendix of the deck, that I invite members of the commission and the public to spend some time with. Our first step, of course, was to share these findings with you. We will also be sharing them with our stakeholders. We actually have a meeting scheduled tomorrow with a broad group of labor representatives to go through these findings. And we'll be folding these findings also into our ongoing engagement work, as it's an important data point, as we said. What we presented here is a summary of key findings, but we're also working on a more comprehensive summary, which we will publish on our website and make available to anyone who wants to dig into this a little bit further. But we have already begun using the survey findings in the process that we're undergoing now to develop our procurement strategy. So that concludes this portion of the presentation. Happy to answer questions or get additional feedback from the commission.
Yeah, Bobby has her hand up.
I just wanted to thank everyone on the team for working on this survey and collating the results. It's really quite fascinating. Even though we sort of maybe have talked about some of those issues and had some idea as to what our members want, this is really terrific. And I just wanted to thank everyone on the team for all the hard work. And I'm very much interested in receiving more information about the breakdown of those respondents. And 60% of members who prefer this, what is that group made of? What's the composition of that group? And I'm very curious whether a lot of the younger subscribers are in family plans, because that would be important for us to know. Whether they are more or less likely to move, from one plan to another. So, as well as the, ethnicity of that group and age, of course, is a big factor, but there are a lot of others. So I'm very curious about, getting those results. So thank you again, Margaret, and the rest of your team, and Matt. It's a job well done. So thanks.
Thank you, Madam Vice Chair. It's been a lot of work on the part of the team.
All right, let's move on.
All right, terrific. Thank you for that. I think here I want to hand it over to Margaret Anschutz, Manager of Healthcare Analytics, and I believe she'll be introducing Sabrina on her team to provide some really interesting data on COVID-19. Margaret?
Thanks, Matt. Yes, it's my great pleasure to introduce Sabrina Wirtz, our intern in health analytics. She started in June. She came to us via Harvard School of Public Health to do her summer practicum. I also have to mention that she is in former GIC Commissioner Nancy Turnbull's program and getting her master's in health policy. Sabrina, again, started in June. She quickly learned our new data warehouse, all of our related data caveats and policies, and pulled together this excellent COVID-19 report on our membership that I'm very excited for the commission to see. And with that, I'm going to turn it over to Sabrina.
Thank you, Margaret, for that introduction. We can move to the next slide, please.
Your volume's a little low, Sabrina. If there's a way to... Perfect.
Is that a little better? I have to hold the speaker straight up.
Thank you.
Okay. Perfect. Okay, so I will be presenting an update on how COVID-19 is impacting the GIC member population between March 2020 and March 2021. And this data will be based on claims paid through June 2021, unless otherwise specified. And then I'll also note that all of our data is being pulled from the MedInsight Milliman database. We switched from the Optum system earlier this year, so really excited to share some of the analyses that we were able to do using this new MedInsight system. And the reason we stopped at March 2021 was just due to the lag time in getting new data uploaded into the system. But where I can, I'll attempt to offer some additional perspective on trends extending into the later months of 2021. So just looking at this map here, this is a map of Massachusetts showing the distribution of COVID diagnoses in the GIC member population by subscriber home zip code. So note that this is not by the zip code of the location of diagnosis. And so the bigger the circle, the more COVID diagnosis in that region. Next slide, please. Great. So here we're looking at COVID-19 confirmed positive diagnosis by both age and sex. We have our number of diagnoses along the left and our age band along the bottom. We're representing females in blue and males in orange. So between March 2020 and March 2021, about 20,000 GIC members had a confirmed COVID diagnosis. That's about 4.5% of the total GIC member population in this time frame. And then for comparison, during these same months, about 9% of the total Massachusetts population received a COVID diagnosis. The other thing I'll point out here is overall, women and men account for about the same number of COVID diagnoses over this time frame. The GIC membership distribution by sex was 54% female and 46% male in these months. And then the last thing I'll point out is this 85 plus age band here. You'll see that there are far more female COVID diagnoses than male. We suspect that this is likely due to the female leaning nature of nursing homes in the state and nationally, just because females have a higher life expectancy, which is reflected in nursing homes.
A question for you, Sabrina. This is Matt.
Yeah.
Is it fair to say that these findings are reflective of what we see in our claims data? So yes. Therefore, if individuals who are GIC members had a positive diagnosis for COVID, but it did not generate a claim, then that wouldn't be captured here. So that the number may be higher and is probably likely somewhat higher.
Yeah, I think that would be fair to say. So yes, all of this is based on claims data, and the way we tracked a confirmed positive diagnosis was by pulling one of 3 COVID-19 diagnosis codes off of the claim. So yeah, that would be fair to say.
Great, thank you.
Next slide, please. Okay, great. So here we're looking at COVID-19 confirmed positive diagnosis again, but by year, month, and sex. Again, we have our positive diagnoses along the left and our years and months along the bottom. So as expected, we see our first spikes in diagnoses in April 2020 and May of 2020, the earliest months of the pandemic. Then we see that dip in the summer months and then a rise again starting in November, December, and then moving into January during those winter and holiday months. And then just to follow up from my nursing home comment on the last slide, you can see that in April and May of 2020, there are slightly more female diagnoses than male. And if you'll recall, this is when there were very high rates of COVID in nursing homes. Any questions on this slide before I move on? Okay, next slide, please. So here we're looking at COVID-19 cases by race and ethnicity. So the Group Insurance Commission is currently in the process of collecting race and ethnicity data. So these are not GIC data, they're pulled from the Massachusetts Department of Public Health. And what we're looking at is all-time COVID-19 cases through September 21st of this year. So these are self-reported identities. You'll notice that the unknown, missing, or refused category was a common response. So these data are far from perfect, but nevertheless, we can still get some important information about disproportionate burdens on different population groups. So we see that white non-Hispanic individuals account for 71% of the total Massachusetts population, but only 37% of COVID cases represented in this chart, whereas Hispanic individuals account for 12% of the total Massachusetts population, but 21% of cases represented in this chart. So we can really see that Hispanic populations are bearing a disproportionate burden of COVID cases in the state. The other thing this chart underscores is just the urgency of collecting race and ethnicity data accurately across populations at both the GIC and elsewhere. The size of this unknown, missing, or refused category could explain why the Black non-Hispanic and Asian non-Hispanic groups have lower percent of cases than we might expect given national level trends about disproportionate burdens of COVID in these populations. So I think it really underscores the importance of getting this data right. Great, next slide. So here we're looking at inpatient admits by both month and year. We have our number of admits along the left and our months along the bottom. 2019 is in blue and 2020 is in orange. So you can see there's a significant dip in inpatient admits in April 2020, sort of right where your eye is drawn. And then those admits begin to rebound in May and nearly return to 2019 levels by June, but they never, quite equal 2019 levels. And I do just want to make a quick distinction between inpatient days and inpatient admits here. So, despite this dip that we see in April 2020, hospitals were still very full at this time. Number of intensive care unit days actually increased because of severe COVID cases. It's just that the total number of admissions decreased. So if this trend line were plotted out by days rather than admits, we would see a different trajectory. And according to the Health Policy Commission in Massachusetts, about 20% of inpatient admits in April of 2020 were related to COVID, and then that share decreased gradually afterwards. And then looking overall, there was about a 10% decline in inpatient admits comparing calendar year 20 to 19. Next slide, please. Okay, so we have a similar chart here, but now we're looking at outpatient visits rather than inpatient admits. Again, the April 2020 dip is the significant takeaway here. You might notice that outpatient visits are slower to rebound than inpatient admits, though they follow sort of a similar trajectory. This makes sense to us. The severity tends to be a lot lower for outpatient visits than inpatient admits, so we would expect these outpatient visits to rebound at a slower rate. Non-urgent care and elective procedures were really the types of care that were skipped here. And then just a note on policy context, the Massachusetts Department of Public Health directed hospitals to cancel elective procedures starting in March 2020 until either rescinded by the Commissioner of Public Health or until, excuse me, the end of the state of emergency, which ended up being June 15th of this year. So that definitely impacted the trends here. And then looking overall, there was about a 16% decline in outpatient visits comparing calendar year 20 to calendar year 19. Any questions on this or any of the prior slides? I'll just pause for a moment.
Jane has her hand up.
Yes.
I'm fascinated by the slide that you showed earlier that I don't, if you could bring it back, or if you recall, where it said looking at Black and Hispanic COVID cases.
Yeah,
and,
I think that was a couple slides earlier.
Yeah, and what I noticed is that it says that there are 6% of cases compared to 7% in the population. My question is, how does that compare to national data? Because my understanding of national data is that there is a much wider gap between the population and the number of cases that we've experienced. So that's one question. So my question would be, so what accounts for that percentage that's displayed? The second is there any information on the deaths that have occurred as a result of COVID by race and ethnicity?
Yeah, so two great questions. The first, you're absolutely right. These numbers don't compare to national trends in a way that we would expect. One hypothesis is just the size of this unknown category, second from the top, is really obscuring some of the health inequities that we would see if we broke out that category by actual race and ethnicity groups. That's just a suspicion. I can't confirm that, but your instinct that this doesn't look quite right, I would agree with. And I think it has to do with that unknown, missing, or refused category. So I hope that answers the first question.
It
Sabrina,
does.
I just want to jump in here too on that very important point is the takeaway for me is the imperative to collect this data ourselves. If we if we don't have the data, we can't get an accurate snapshot of what's going on. And DPH has some of the data, but clearly that unknown, missing, refused, it just skews our ability to do the analysis that this question merits.
Margaret and Sabrina, I so appreciate what you just said, because, when we think that we're broadcasting this information to the public, I would be very concerned to have anyone think that this is accurate, and I have to just confess that my lived experience as a Black woman tells me it's not.
Yeah.
So that's
Absolutely.
why I asked the question. And then on the death question, I am very happy to be proven incorrect with the data, but again, I see a disproportionate deaths that occur in the Black and brown communities. So I'm just trying to sort it out in my own head. Thank you, though, for your comments. I appreciate that.
Of course, yeah. And then to your question about COVID-19 deaths, the Department of Public Health tracks that metric as well. We've just not shown that here. And we can pull that information for you broken out with race ethnicity data from DPH if that would be of interest. Any other questions?
I don't see any.
Okay, perfect. Thank you. Okay, so here we're looking at office visits by age band, month, and year. And so we have our number of office visits along the left-hand side, and then our months along the bottom. And so these are office visits to a primary care physician or specialist, and they're broken out into 4 different age bands. We have 0 to 7, 8 to 24, 25 to 64, and 65 plus. And you'll see for each of these 4 age bands, office visits dropped steeply in April 2020. But while the 3 older age bands begin to rebound, the 0 to 7 age group increases marginally, it looks like in June and July, and then almost completely levels off. So what this is telling us is that young kids are not returning to their primary care physicians, which is a trend that's consistent with broader trends identified by the Health Policy Commission in previous COVID impact reports. And it's actually holding through Q1 and Q2 of 2021. So we're not seeing this younger age group starting to return to their PCPs at higher rates this year either. Next slide, please. So here we're looking at outpatient emergency department cases by month and year, again with the cases on the left and months along the bottom. We see that familiar April 2020 dip. And just to offer some additional insight here, this general trend holds for both males and females and across all age bands. And looking at the years overall, emergency department cases dropped by 19% comparing calendar year 20 to 19. Next slide, please. Okay, so we're really excited about this last slide. We think it really demonstrates how the rapid adoption of telehealth helped to maintain access to services. So we have our number of psychotherapy visits along the left and our years and month along the bottom. In blue are non-telehealth services, and in orange are telehealth services. So you can really see prior to March 2020, psychotherapy services were rarely delivered via telehealth. Telehealth access to psychotherapy was expanded due to the pandemic, and well over half of all psychotherapy visits between March and December of 2020 were delivered via telehealth. So we looked into early 2021 data, and that indicates that telehealth usage is still really strong. There's been some return of in-person visits, but telehealth is still accounting for over half of those visits per month. These data don't include employee assistance program therapy visits, but these trends really aren't driven by EAP visits. They're driven more by access through our carriers. And then just to offer a little bit of policy context here, the GIC chose to waive cost sharing for telehealth services during this time to support members, which was a really important piece to expanding access. And that provision was in effect until June 15th of 2021, which was the end of the Massachusetts state of emergency. And then beginning in January 2021, the state passed legislation on rate parity for in-person versus telehealth services. And prior to that, there was a temporary provision for rate parity in 2020. So both of those things are affecting the trends here as well. So this is a really good thing and consistent with our strategic objectives. And we're watching closely to see how we can use telehealth to continue to expand access to services in the future. And next slide, please. So that's all I have for you. I just have some data notes here if you're curious about how we defined a COVID diagnosis or the various indicators we used to pool psychotherapy or telehealth visits. I'll pause for questions, but thank you.
Yeah, I'm wondering when the data will be available post the co-pays on telehealth being waived. Do you have a sense at all if the volume decreased once the copay waive was not in play?
I'm actually not sure, but I can look into that and get back to you.
Yeah, I'm sure the data is not keeping up, so we'll need a little bit more time, but it would be interesting to see if that was indeed a determinant of the large increase. I'd love to see it continue. I think it helps with our constituents getting the access they need and deserve. But let's just see if we can get an answer to that question.
Sure.
I don't see any other hands up. Very nice job, Sabrina. It's been lovely to have you a part of the commission, and best of luck finishing up all your work academically.
Thank you very much.
All right, Matt, back to you.
All right. Thank you, Sabrina. Thank you, Margaret. We're now going to move back onto our third, well, it's our fifth agenda item, but our third kind of non-routine item. I'm going to hand it over to Jim Rust to introduce our colleagues at CTI who continue to do really excellent work for us in monitoring the performance of our health plans to make sure that we're getting as much value as we can from those relationships. Jim?
Good morning, everyone. I'll turn it over to Michelle Succo from CTI, who performed the audits on our plans this year. As you know, we audit 3 plans every year, so every other year a plan is audited. She'll present the results of her audit, including some recommendations. I don't want to steal her introduction from herself, but she's going to go over the parameters of the audits. But just a reminder here that I will be presenting a short summary of the follow-up from the prior audits during my CFO section at the end of the meeting. So you can have questions on any of the prior audits, we can take them. So I'll turn it over to Michelle Succo to walk us through the audit results.
Great, thank you, Jim. Can everyone hear me okay?
Yes, you sound great, Michelle. How are you?
I'm great, thank you. Well, good morning, everyone. I'm pleased to be here again presenting audit results on behalf of the GIC. My name is Michelle Succo. I oversaw all of these audits this year. And while I'm here to present results today, I just want to remind everyone that we aren't finished with this process. There's a lot of post-audit work that will occur with each of these administrators that were audited to see these audits to completion. We don't simply want to just hand the reports over to the GIC. We want to actually make appropriate improvements to improve the audit results a year and a half from now when we are actually back in these administrator shops. With that, before I get started, I just want to express how thankful we at CTI were with the cooperation of each of these 3 administrators. Once again, with COVID, we were unable to go on site and perform these audits. We did perform these audits remotely. We are confident in the results. The drivers and the system access that we were given did not in any way compromise the quality of the audits. And so I just want to thank all 3 of the administrators for their flexibility, their cooperation in working together with us during these unprecedented times. Next slide, please. The audit objectives were to make sure that claims were processed according to your contract terms with each of the administrators, verify that the plan document provisions were clear and consistent, verify that members were eligible at the time the service was incurred, and then if there were any opportunities that might present themselves for process improvement or cost containment strategies, we noted that as well. Next slide, please. Our comprehensive audit contained the following audit components: a statistically valid random sample of 200 claims, 100% electronic screenings of the entire universe of claims with 150 targeted samples. Data analytics to verify provider discounts, coding initiatives, compliance with Preventive Services ACA, an extensive operational review that included management interviews, and then a plan document review and analysis. Next slide, please. This slide really summarizes the volume of claims and the dollars paid for each of the administrators that we audited. The audit period was July 1, 2019 through June 30, 2020, incurred claims, and then paid through year end, calendar year 2020. You can see by looking at this chart that Unicare had the most claims paid and the highest amount of dollars paid. So you can compare and contrast the volumes paid for each of the administrators here. Additionally, you will see on this chart median turnaround time, which ranges from 1 day with Unicare to 21 days with Fallon. Next slide, please. The random sample audit results are broken out into quartiles. This is our benchmarking chart that you're seeing here. We have taken the last 100 audits that we performed at CTI, and we have broken each of those into quartiles of 25. Quartile 4 is the highest performing quartile. Quartile 1 is the lowest performing quartile. We have proprietary software here at CTI that allows us to audit each and every administrator the same. Our auditors are required to answer and respond to certain questions before moving on. Therefore, our benchmarks are very reliable across administrators and amongst our own internal auditing staff. The median represents the point at which 50 audits performed above and 50 audits performed below. So you can see for the 3 administrators that we audited, for the 3 key performance accuracy measures that we captured, only 1 metric fell above the median, and that is financial accuracy for Health New England. The remaining fell below the median, with 4 in quartile 2 and 4 in quartile 1, which is the lowest quartile. Now, part of our post-audit action planning will be working with each of these administrators to get these key performance metrics up above the median benchmark. The goal is to get all of these administrators' performance above CTI's median benchmark. Next slide, please. Key findings for Fallon. Through the random sample, Fallon's overall accuracy rate was 98.11%. We identified 9 claims with payment errors, and you can see the breakdown between overpayments and underpayments. Of those 9 errors, 7 were automatically adjudicated or without any human intervention. Now, anytime we see errors attributed to auto adjudication, we know that there are more errors attributed. There's some sort of system configuration error that's occurring that is causing those claims to be incorrectly adjudicated. So again, as part of our post-audit follow-up, I will be working with Fallon to pull impact reports, identify additional impacted claims, and then we will work with Jim and team on next steps and remediation. 6 of those 9 errors were attributed to copayment errors. For the 100% electronic screening with 50 targeted samples, we had an overpayment of limited services with regard to applied behavioral analysis. We saw positive findings with regard to end-stage renal disease, incorrectly paying claims as primary versus secondary to Medicare. We saw payment of excluded services for pre-employment physicals, and we saw assistant surgeons not being held to the 80 to 90% reductions that they typically are held to. Again, incorrect co-payments showed up on the electronic screening portion, as I reported earlier. for the random sample as well. We also ran 100% of the claims through and bumped against the GIC's eligibility. We did have some small findings there. Only 0.18% of the claims were paid for people who may have been covered by GIC at the time the care was received. CTI typically sees 1% or less, so you can see just how well the GIC is performing and how timely and accurate their eligibility results are. Next slide, please. H&E key findings. Again, H&E had the best financial accuracy rate at 99.14%. We identified 8 errors with payments. You see the breakdown between overpayments and underpayments, relatively small dollars. 7 of the 8 errors were adjudicated manually. Now, unlike what we saw with Fallon, manually adjudicated errors are attributed to human error. Those are a little bit more easily corrected because you can verify that your policies and procedures exist and are clear. You can provide some one-on-one coaching and retraining with the examiner. Typically, these are one-offs. These are just manually processed errors, and the impact is minimal. 4 of the 7 errors were also attributed to copay. So you can start to see a theme here. And actually, when I report on Unicare, you will see that 3 out of 3 administrators had their top reason code attributed to copay calculation errors. In terms of the 100% electronic screening with targeted samples, I'm sure this bullet point, this 4.9 million, will probably jump off the page to you. And I am not in any way suggesting that H&E owes the GIC 4.9 million. This is a potential where there may have been third-party liability exist. So anytime there's an accidental injury on a claim, we would expect the claim to have been investigated to determine whether or not there is third-party liability that could be subrogated against and ultimately money credited back to the GIC. These claims were not tested. This is the pool of claims that went untested through the 100% electronic screening. But that number is high enough that I will be working with H&E to tighten their investigation procedures going forward. We did have positive findings for a dog bite and a product liability that should have been investigated and were not investigated for third-party liability. So again, we will work with H&E post-audit to tighten those investigation protocols, identify third-party liability when appropriate, and make sure that those monies are credited back to the GIC. We saw an overpayment of limited services. Nutritional counseling is limited to 4 visits per plan year. H&E acknowledged that this was a system configuration error that has now been resolved. However, it had not been resolved at the time the claims were adjudicated and pulled for audit. And much like the prior slide, only 0.023% of claims were paid on people who may not have been covered by the GIC at the time. So again, eligibility records, very, very accurate and timely with regard to communication to H&E. Next slide, please. Unicare findings, and my apologies, this font is very small. You do have a copy of this in your packet. I will highlight some of these findings for you. The financial accuracy rate for Unicare was 92.42%. There were 20 claims that had payment errors, and you see the breakdown of overpayments and underpayments on the slide. Just about $22,000 in financial errors made by Unicare. 14 of those 20 were adjudicated automatically. So much like Fallon, this will be an area where I work with as part of post-audit activities to pull impact reports to identify other impacted claims that were auto-adjudicated incorrectly. And 7 of the 20 claims were attributed to copayment errors. In terms of the 100% electronic screening, again, we found positive findings with members with end-stage renal disease, a potential paid greater than charge, potential PPO provider without discount, payment of excluded services for hearing aids and supplies, genetic counseling, and nurse surgery assistant. We saw over accumulations in deductible and out of pocket due to incorrect deductible application. We found opportunities where abusive billings were occurring. Specialty medications were being paid without being reviewed for medical necessity. Chiropractic upcoding, the procedure code indicating the number of spinal regions being treated was not supported by the spinal regions indicated in the diagnosis code submitted on the claim. And then we did find services for repeated labs for genetic testing were paid without documentation to support medical necessity and the rationale for repeating that genetic lab. We found some overpayments for limited services around partial hospitalizations not being reviewed for medical necessity. Sleep studies were not being prior authorized or reviewed for medical necessity, and incorrect co-payments for occupational therapy and high-tech radiology. Most of these errors were manual. And so again, as part of post-audit, we will be looking at ways to either leverage automation and take the manualness out of this bucket of claims, or really strengthen the coaching and training with examiners and manual processors to prevent similar errors going forward.
And
again, yes, go ahead.
I'm wondering how much of, so from a timing perspective, it might not be a relative question, but do you find that any of these errors have to do with employees going remote during COVID, or does the timing not line up?
The timing does line up. Also, Unicare reported that they had some backlog situations in their claims area, and they outsourced to a subcontractor, and many of the errors were attributed to the subcontractor. Okay. So again, one of the post-audit action items will be if and when subcontractors are used, appropriate oversight monitoring in terms of accuracy should be added if it hasn't already. And Unicare has had our work papers since we performed the audit, and I'm sure they are probably doing some deep dives into our findings and probably putting procedures in place in advance of these post-audit activities that will engage following this presentation.
Okay, thanks.
You're welcome. And again, 0.30% of claims were paid on people that may not have been covered. So again, less than the 1%, GIC is doing very well with regard to eligibility maintenance. There was one other area with Unicare that did not show up with the other two administrators, and that has to do with subrogation, third-party liability, and any sort of authority limits in place. So currently there are no authority limits in place with Unicare that would require the GIC to approve or sign off on any request to reduce its lien against the third party. And so that, again, is one of the areas that we will be working on to put that process in place going forward with Unicare as part of post-audit. Next slide, please.
Sorry, I think we have our vice chair has her hand up.
Oh, thank you, Matt.
Yep.
Yes. Hi, Michelle. I'm very curious about the subcontractors. Is that, does each health plan, like does Fallon and, Health New England use subcontractors? Is that a common with health plans? And do we have any sense of what they use the subcontractors for? In what areas? And are there policies that Unicare has or any other health plan regarding their subcontractors?
Yeah, great question. As part of our operational review questionnaire, we do ask if any subcontractors were used and what their services were used for. We do also ask what sort of monitoring of performance takes place. So every administrator that we audited in some capacity is using some level of subcontractor. We found that Unicare, because of their claims backlog situations, relied on its subcontractor to help reduce those backlog situations. And so while they may have some sort of measuring and monitoring in place, we identified some improvement opportunities there that we will be having discussions with, again, as part of the post-audit action planning sessions that will be occurring.
Thank you.
You're welcome. Some key findings across plans. Specialty pharmacy rebates typically average about 2% of the drug cost for any sort of specialty pharmacy medication that is paid under the medical plan. Now, again, the vast majority of your pharmacy claims are paid under your pharmacy or by your PBM, and you get rebates from the PBM. One of the things that we ask every administrator that we audit is, are you getting rebates for specialty drugs paid under the medical benefit? And if so, are you sharing those with the client? Are you passing those through? Fallon was required by contract to establish a pass-through process to share those rebates with the GIC. However, at the time of this audit, that had not been done. And so the GIC should follow up with Fallon on when that will be done. I will also put that on my post-audit action plan to make sure that we can get some sort of firm commitments from Fallon as to when that process will be in place and as to when the GIC can expect to receive those rebates. H&E and Unicare are following their contractual requirements. We did find, as part of the operational review, inadequate GIC specific overpayment reporting. And so again, as part of post-audit action, we will be working to get GIC specific overpayment reporting reports provided to the GIC folks. Data analytics. While the majority of the CMS edits are in place with the 3 administrators that we audited, we found 2 audits or 2 areas where there could be enhancements that occur. CMS is the largest payer in the nation, Center for Medicare and Medicaid Services, and they have developed a standard set of edits for National Correct Coding, or NCCI, and global surgery. These edits are made available free of charge. CMS updates them on a monthly basis. And so we screen just to see how many of those edits are in place by each administrator that we audit. We typically see 0.50% or less when compared to the audit universe. And all 3 of the administrators that we audited this year are above that normal percentage rate that we typically see. This is an area where there is no requirement for commercial carriers to adopt CMS edits, and we are not we are not in any way suggesting that these administrators replace their current editing system. We are simply recommending that they enhance or augment their editing system with the NCCI and the global surgery edits. And you can see how each of the administrators compare to that 0.50 benchmark that we typically see with other administrators that we audit. So again, this will be part of the post-audit action planning to work with each of these administrators and have conversations around enhancing current code edit systems. Our belief here at CTI is if CMS, the largest payer in the nation, would not pay for a certain code combination or more than X number of units on any given day, why would the self-funded plans that we audit on behalf of want to pay for something that the largest payer in the nation would not pay for? So again, I will facilitate those conversations with each of the 3 administrators as part of post-audit action planning activities. Next slide, please. In terms of recommendations, a lot of these I've gone through as part of my commentary around post-audit action planning. Obviously, we want to get those random sample results up above CTI's median benchmark performance. In terms of the ESAS targeted samples, we want to identify if overpayment recovery and/or system improvements are possible, and we want to eliminate or prevent similar errors going forward. Again, we can provide listings in each of those categories to the administrators. I see a hand up. Is there a question?
Yes, I'm just very curious what claims were paid that would have been denied by CMS. I'm curious about the categories or the types of claims that were paid, and I'm wondering if you would have that information.
Sure. So there's 2 main categories where we believe offer the greatest potential for the GIC. Under the National Correct Coding Initiative, or NCCI, there is a procedure to procedure edit, which says if you have this procedure code as your primary build, you are not allowed to bill separately for this secondary procedure. That's a form of unbundling that's not allowed by CMS. And so we saw this primary and secondary combination with both the primary and secondary being paid. CMS would have denied that secondary procedure. And there's you know, thousands of those code combinations that CMS screens for. The second is, it's called the MUE, or the medically unlikely edit. And it is a frequency edit. And it is saying for each procedure code, it is medically unlikely that you would have more than X number of services on any given day. And so anytime we saw those frequency limits exceeded on a per procedure basis, that popped out as a defect, and that's where those percentages that were reported on the previous page came from. And then the third is global surgery, and every surgical procedure has a value assigned to it, either 0, 10, or 90. And what that means is there is post-surgical follow-up that needs to occur. And if it's within 0 days, you can't bill it separately. If it's within 10 days, you can't bill it separately. That's part of the surgical global procedure. If it's within 90 days, you can't bill it separately. Now, there may be some complications of surgery, and there's some modifiers that providers can use to indicate those outlier situations. But we do screen for those modifiers. And so the fallout that we reported are true claims that had a separate identifiable office visit billed within that prohibited fee period time frame.
Thank you very much. Yeah, that really, that does really help. Thank you for the explanation. I appreciate it.
Great, thank you. So that really is number 3, the data analytics section. And again, as part of post-audit follow-up, I will be working on that as well. Item number 4, because there was positive findings, albeit very, very small percentages, we do recommend that the GIC take a look at the eligibility results just to identify whether or not there might be an opportunity to improve workflow to reduce or eliminate paying claims on ineligible claimants going forward. Again, in the grand scheme of things, this is not a super high priority. However, because there were positive findings, it is showing up as a recommendation. Next slide, please. As we previously discussed, Fallon did not have a process in place to pass through rebates. So again, we will work on that as part of post-audit and get that process established on behalf of the GIC. Again, authority limits with regard to third-party liability, we've discussed that, and overpayments, we've discussed that. Any questions on the findings, the recommendations, or next steps in terms of what I'm going to be working on with each of the administrators to prevent similar errors going forward and improve the audit results?
I don't see anybody. I don't see questions. I thought you were very thorough in your review, Michelle, and very helpful in answering the questions. So thank you.
Thank you, Madam Chair. Appreciate the feedback.
So before we go on, just I want to say a brief word about this. First of all, to thank our colleagues at CTI for the excellent work they do on our behalf. These reports clearly are very helpful to us at the GIC as we seek to make sure that our contracted plans perform well and that they are compliant with their contractual obligations to the GIC. They point, as we can see here, to a number of areas where effectiveness of the plans can be improved, particularly in this case around claims payment accuracy, where the Massachusetts-based plans typically perform pretty well. So I think we have some room for improvement there. The issue around pharmacy rebates on the medical benefit is one that we've seen before with one of our other plans last year. So this is clearly an area where we need to bring some greater clarity and accountability to that. So we will certainly do that. I do just want to note what Michelle noted at the outset, which was there is still process to go here, right? These are findings of the audit. We have already begun to engage with the carriers to further understand the findings and make changes where they are necessary. So we, and I will say that the carriers have been good partners in this, and we continue to expect that they will going forward. So.
Very good. Thank you, Matt.
Thank you.
Any other questions?
Yes, Michelle, I just have one. Do you know what the dollar amount, regarding the rebates that aren't being passed through? What is that dollar amount that is being lost?
Well, it's approximately 2% of anything that is going through as a specialty drug under medical. And I do not have that figure readily
Okay.
available.
All right, would you be able to get it though? Would you be able to provide that?
I could get that by running a report for the specialty drugs that were processed during the audit period. However, that number is just going to be limited to fiscal year 20. And so that number is going to be, just a portion of the overall.
Right, I understand. Thanks.
You're welcome.
All right, let's move on in the interest of time. I know, Jim, you were going to summarize audits from previous years and other plans, and then take us through the budget numbers.
Sure, I'll do that. And I also want to thank Michelle for you and your team's great work. And I should pass along that the plans have passed along to me as I've met with them just this week on some of the audit results, that they appreciated the professionalism and the approach of CTI to these audits. And so we appreciate that as well. So thanks, Michelle.
Thank you, Jim.
Okay, so I'm going to do my CFO report here. I'm going to mostly focus on the audit update. You have the slides with the financial results, and it's been a pretty data and number heavy meeting, I know. And we're just through, so why don't I do that first really quickly? We're just through the first quarter of the year, and we're basically on budget. And I have the usual COVID stats on payments and whatnot, but we got a much more detailed presentation from Sabrina on that today, so I think you have a good feel for that. So there's really no new news on the budget side. We seem to be tracking right about our budget for the year through the first quarter. So you have the information on the slides. As always, you can reach out to me with any questions. Next slide, please. So here, just to recap, I'm not going to read all these to you, but these are just to refresh your memory. These are in your deck. These are the recommendations from last year's audit of the 3 plans of Tufts, Harvard, and Always. We've been, as Michelle mentioned and Matt mentioned, this audit process is a continuing process, right? So we talk to the plans all the time about these results. CTI helps us also work with the plans so they can improve their performance. I can report that to date, the plans have all responded to these findings in a way that has resolved any issues that are outstanding. We are getting the medical pharmacy rebates back from plans when we weren't before. All the plans are operating and paying under their contractual obligations. So that's the high level summary of where we ended up on last year's audits. I should mention that the plans have been very responsive. Tufts and Harvard have both put resources into improving their processes where they needed to. Always is also engaged with outside firms, including CTI, to improve their processes as a result of the audit. So we're very pleased with their responsiveness and their ability to try to improve in the areas that the audit pointed out. I also want to make a quick comment on how the audit process works. So when we say it's a continuous audit, it really truly is. We meet with the plans every 2 weeks on where they are on various items. We also have another audit process where the plans have to produce what's called the SOC 1 report for us every year in October. That's an audit of their own operations from their side, where they use an outside auditor to look at their operations and their security. So we have those now, as we do every year. We review them. We then give those to the state as part of the Commonwealth's audit, and they review them. So my general point is not to bog you down, but there's a lot of auditing going on. We stay on top of it. The plans are very well supervised in this regard, and they're very responsive. So I don't think we went through that process last time. So I want to give you a feel for the whole cycle of the audits. Next time CTI audits these 3 plans, we'll benefit from the fact that it'll be the second audit with those plans. So all the results will be benchmarked based on the first audit. So we'll get to see a progression of improvements particularly in their processing and those kind of things. We'll get to see things such as whether they have repeat issues or if dollar values have increased or decreased. So next time around, when these audits start this year on these 3 plans, we'll have a even better sense of the great work CTI has already done of where they are and how their processes are trending. So that's a pretty brief and high level update on where we are on last year's audits. But if you have any questions, I'm happy to answer them.
I raised my hand, Jim. This is Toby Choate. I'd like your opinion on you foresee any issues with Harvard and Tufts coming together. I assume they're going to combine their claims processing operations sometime and put it on one system. which obviously makes sense to get the cost reductions. But that, I'm sure, is a laborious process. Do you have any sense of how that's going to go?
That's an excellent question. I think we're at the early stages of discussing that with them, because right now they are paying as separate entities, but it is on our transition plan to stay on top of that. They haven't indicated to us that they have any issues at this time, planning that going forward. But I can look, basically all I can say at this point is it's on our radar, it's on their radar, it's part of our things to discuss, but it's not anything that's right around the corner. I think it's going to take, as you point out correctly, a while. So I think we'll be all over it.
Do they have a target date for when they're bringing all their operations together, by any chance?
They have not communicated that to me. I don't know if Matt or anybody else.
So there actually has been a little bit there, and so I would say there's an implementation plan that they've shared with me, that we've reviewed, that is very mindful of our transition from our current procurement and contracted relationships with them, leading into the next procurement. So as it relates to the migration of the claims platform, I want to be careful not to say more than I should in a public setting, but we are, I have all of those timelines right in front of me, and I'm comfortable with the way that they've communicated them to us, and that it's being done in a way that is specifically mindful of our transition and our members.
Okay, thank you.
Yep.
I'd also like to point out that we've already talked with the plans, these 3 plans that were audited this year. Unicare has resolved some of these issues already. We've come to learn. Obviously, CTI will go back in and confirm that. Things like such as, I believe we had a question about the subcontract. That subcontractor was removed during the audit period, so they're already not on the job anymore. Those kind of things. So we were happy with the feedback we got from the plans. Is my overall point. Like initially, just as we sat down with them right before this presentation, as to what we were going to be presenting and what they needed to do. So we feel like we're on a good track to resolve most of these things. With that, I'm happy to answer any other questions on this or on financial performance for the quarter.
Sorry, let me just say one other item as it relates to the audits, and that just one other way that they will be, that they are and will continue to be helpful to us as we go into the next procurement and develop the specifications for the RFR. These audits surface a variety of performance-related metrics that again we can use to address through the procurement and through our contracting with our health plans, right? We will be establishing a set of quality benchmarks as it relates to all of their areas of performance. So this is yet one other set of data points that will inform the development of our RFR and our strategy going forward.
No, I think that's great. And I like the review from last year's audit and the fact that you're on top of it, talking to plans on a regular basis, you know, I think is important to all us commissioners. So thank you.
Okay, thank you.
Yeah, my sense is that it's probably worth doing this as a normal routine feature. Whenever we bring health plan audit findings to you, we should also review how the issues that we surfaced and for the prior year and the other 3 plans have resolved. We'll continue to do that.
Mm-hmm. Nice. All right. Well, thank you. I don't see any other questions from commissioners. I think that was our last agenda item.
It is. I do just want to make a couple of quick notes on other business and adjournment here. And just to note the second set of bullets there around the exceptions to our normal calendar. We have made a few adjustments with feedback from the commission for some of our meetings in 2022. Those are reflected in the calendar and the subsequent slide. Just want to note that to make sure that commissioners are holding appropriate dates, and those who are following are aware of those changes.
Do you want to pop that? Can you pop that up one more time just to have that be one of the final agenda items, or is that too challenging?
No, I think that's the next slide.
Oh, I set you
My
up so
memory
well.
serves. Yeah.
Good. And so our next meeting is, let's see, can't possibly be November, is it?
November 18th.
Where's the time going, everyone?
Hmm.
Okay, and we'll continue virtually for quite a while until you let us know. And you're still moving into the space at the McCormick building, but settling in nicely from what I'm told.
We are, we have, and we are. Today, as on many days, I'm the only one here. We do occasionally have folks in the office. Folks on the mailroom side, as we know, continue to come in to perform those functions that need to be performed in person. And, you know, but for now we are in the kind of status quo of not requiring our staff to come in and feel quite comfortable with the level of performance and effectiveness of our team in that environment. So. And
staff morale still staying at a good clip despite the pandemic. They have access to our EAP.
Yeah, no, it is. And I would say there is, you know, this sort of anecdotally kind of growing desire to, you know, when the time is right for us to start to have more of an in-office presence as we need to have. And so I and others are eager to start to reintroduce some of those, some of that in-office presence, just to, if nothing else, just to see each other in person once again, which many of us haven't in quite some time.
Yes. Okay. Well, I don't have any more questions. I have enjoyed this meeting, waiting a while for the conjoint survey. And so thrilled to have those results and know they'll be part of what's informing the staff and the discussions with stakeholders over the next several months leading up to the RFRs that are going out in early 2022. So those of you with constituents, please make sure that you're disseminating the information and reminding on the procurement that this is a big opportunity for input from all stakeholders, and you know, we welcome continued dialogue at the next GIC meeting. So if there's no other business, and I don't see any comments, I'm going to give you, let's see, I'm going to give you 7 minutes back in your day. So enjoy this beautiful day, this beautiful weather in the Boston area, and we'll see you close to Thanksgiving. So thanks everyone. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you.